Good afternoon, my dear students. Yesterday, I started surface anatomy of lower limb. Yesterday, I explained you the importance of studying of surface anatomy, how it is useful in clinical side and also in your practice. So, it is more useful in imaging anatomy. So, identification of underlying structures superficially and marking the underlying structures superficially is surface anatomy. So, underlying structures marking superficially where they are present with reference to certain bony landmarks and others, that is the surface anatomy. Now, yesterday I started thigh. I told you this thigh. Now, front of the thigh. Fold of groin. It is an oblique skin grease which marks the junction of the front of the thigh and anterior abdominal wall and corresponds to the inguinal ligament. Yesterday I told you junction between the upper part of the thigh and also the lower part of anterior abdominal wall is nothing but fold of groin. So underlying that area of fold is inguinal ligament is there. Anterior superior iliac spine. It forms a palpable, occasionally visible elevation at the lateral end of the fold of groin. So, if you go in the junction between the junction of, if you put your finger in the groin, that is junction between the upper part of the thigh and the lower part of the anterior abdominal wall. If you go laterally, you will find a point that is anterior superior iliac spine. Anterior superior iliac spine, because the inguinal ligament is attached between the anterior superior iliac spine and the pubic tubercle. Now, pubic tubercle, it is a palpable small elevation at the medial end of the fold of the groin. So, anterior superior iliac spine is at the lateral end of the fold of the groin, and pubic tubercle is at the medial end of the fold of the groin. In between these two, inguinal ligament is there. Inguinal ligament is nothing but aponeurosis of the external oblique abdomen. So it becomes thickened. So that is the inguinal ligament. So mid-inguinal point represents the midpoint between the anterior superior iliac spine and the top of the symphysis pubis. Now, pubic tubercle and symphysis pubis is entirely different. Symphysis pubis is nothing but junction between the two pubic bones. Junction between the two pubic bones is symphysis pubis. So, mid-inguinal point represents the midpoint between the mid-inguinal point. Midpoint of the inguinal ligament and mid-inguinal point is entirely different, because inguinal ligament is present between the anterior superior iliac spine laterally and pubic tubercle medial. Whereas mid-inguinal point that comes from anterior superior iliac spine to the top of the pubic symphysis, that is a little beyond the pubic tubercle. So, mid-inguinal point and midpoint of the inguinal ligament is entirely different. There is a little difference between the midpoint of inguinal ligament and mid-inguinal point. So, inguinal region means junction between the upper part of the anterior aspect of the thigh and lower part of the anterior abdominal wall, that is the inguinal region or fold of groin. So, that is inguinal region or fold of groin. So, fold of groin. So, you must know the difference between mid-inguinal point, because inguinal point, inguinal ligament exists between the anterior superior iliac spine laterally and pubic tubercle medial. Whereas inguinal fold or groin extends from anterior superior iliac spine a little beyond the pubic tubercle, that is top of the pubic symphysis. That is the analysis you must know here. Now, this is the femoral laterally, femoral artery center part and femoral vein medially. So, these three present in femoral triangle. So, yesterday I told you the saphenous opening. So, saphenous opening. So, great saphenous vein dips backwards into the saphenous opening. This saphenous opening is covered by a fascia, that is cribriform fascia. So, saphenous opening. This is the pubic tubercle. This is the pubic tubercle. So, this is the symphysis pubis. So, this amount is different. So, mid-inguinal point means This is the mid-inguinal point. So from here to here, same distance. From here to here, same distance. But from here to pubic tubercle to here is a less distance. This is a more distance if you measure it. So now, adductor tubercle. It is the highest point on the medial condyle of the femur and can be identified by placing the hand flat with the fingers pointing below on the medial side of the thigh and tracing downwards to the knee. During such procedure, the tip of the middle finger comes in contact with the adductor tubercle, where cord-like tendon of adductor magnus recognized on deep pressure that reaches the tubercle. Why it is called as adductor tubercle? Adductor magnus has got attachment with the adductor tubercle. So adductor group of muscles has got attachment with this. So that's why it is called as adductor tubercle. Adductor means medial movement is adductor. Abduction means away from the center, that is abduction. So adductor tubercle is present on the medial aspect of the thigh, top of the femoral condyle, top of the medial femoral condyle, that is adductor tubercle. So center of the saphenous opening, otherwise called as fossa ovalis. It is represented by a point 3 to 4 centimeter below and lateral to the pubic tubercle. Center of the saphenous opening is otherwise called as fossa ovalis. It is represented by a point about 3 to 4 centimeter below and lateral to the pubic tubercle. So, it is saphenous opening. Regarding this position, this is the letter H. Fossa ovalis, by a point about 3 to 4 centimeters below and lateral to the pubic tubercle. That means you have to read it. You have to see it. You see it, you observe this point, then you read this point. Try to understand by correlating with each other. Okay? Now femoral artery. Find out a point midway between the anterior superior iliac spine and pubic symphysis. Femoral artery. A point midway between the anterior superior iliac spine and the pubic symphysis. I will show you. This is the anterior superior iliac spine. This is the pubic symphysis. This is the pubic tubercle. So, a midpoint between the anterior superior iliac spine and the pubic symphysis is the femoral artery. It is present behind the inguinal ligament. So, femoral artery is present in the midway between the anterior superior iliac spine laterally and the symphysis pubis medially. Midpoint of the inguinal region, mid-inguinal point. Midpoint of the inguinal ligament means anterior superior iliac spine laterally and pubic tubercle disease. That is inguinal ligament. So midpoint of the inguinal region means from here to here, and femoral artery is present at the mid-inguinal point. Femoral artery is present immediately below the inguinal ligament, that is at the mid-inguinal point, but not the midpoint of the inguinal ligament. You must know it. Not the midpoint of the inguinal ligament. It is mid-inguinal region, mid-inguinal point, but not the midpoint of the inguinal ligament. So you see, he has mentioned it here as a mid-inguinal point. That is mid-inguinal point. Another point in the adductor tubercle. Join these points by a line. Find out a point midway between the anterior superior iliac spine and the pubic symphysis. This is the adductor tubercle. Present on femur bone is present in the thigh. So lower part lateral condyle is there and medial part medial condyle is there. So this is the highest point of the medial femoral condyle. That is, on the medial side, adductor tubercle is there. A line connecting the mid-inguinal point to the adductor tubercle represents the femoral artery. If anybody asks you the surface anatomy of femoral artery is nothing but a line. You have to represent the femoral artery, underlying femoral artery superficially by identifying the mid-inguinal point and adductor tubercle and join these two by straight line. So join these two by straight line. So this is the mid-inguinal point. This is the adductor tubercle. You join these two by a line. that represents the femoral artery. That is how you have to represent the underlying structures superficially. That is the how you have to marking, surface marking. If in examination, examiner asks you identify the femoral artery, surface anatomy of femoral artery, you have to first go and touch the point, mid-inguinal point. Then you have to touch the adductor tubercle. Then you have to connect these two by means of a straight line. That is the surface anatomy of femoral artery. So that is surface anatomy of the femoral artery. So underlying is femoral artery. It is represented superficially by a line connecting the mid-inguinal point and the adductor tubercle. That is the medial aspect of the thigh. How you have to answer the in the examination. If the examiner asks you a question, or in any theory paper also they can ask. Now, upper two-thirds of the line represents the femoral artery, which should be drawn when the thigh is flexed, slightly abducted and rotated laterally. Upper two-thirds of the line represents the femoral artery, which should be drawn when the thigh is flexed, slightly abducted and lateral. Upper two-thirds are now. But what about the lower one-third? Lower one-third is present in the adductor canal. It is going to the posterior aspect. So that's why it is shown in the dotted line. That's why it is shown in the dotted line. So you have to draw a line and you show upper two-thirds in lower one-third in a dotted line that is going through the adductor canal into the posterior aspect of the popliteal fossa. This is the popliteal fossa as a popliteal artery. As popliteal artery. As popliteal artery. So you have to do it like this. Now great saphenous vein. This is how. Up to the adductor, lower part of the adductor tubercle and also a saphenous opening 2 to 3 centimeters below and lateral to the pubic tubercle. So saphenous opening 2 to 3 centimeters below and just lateral to the pubic tubercle is the saphenous opening, and a line joining the lower part of the adductor tubercle that is represented by great saphenous vein. That is represented by great saphenous vein. Now femoral vein. Of surface projection of the femoral artery, femoral vein lies close to the medial side of the artery in the upper part and behind the artery in most of its course with slight lateral inclination in the lower part. So femoral vein is not a straight one. So femoral artery is a straight one. In the upper two-thirds, femoral artery is like a line, whereas in lower one-third it goes into the adductor canal. So femoral vein is on medial side of the femoral artery, close to the in the upper part and behind the artery in most of its course with slight lateral inclination in the lower part. Medial side, behind and lateral inclination. So femoral vein, upper part, medial side, then behind the femoral artery, then comes to a slight lateral inclination. So I will show you how the femoral vein. Upper part, medial. This is femoral artery lateral. This is femoral vein medial. Then it is going behind. Then it is going behind the femoral artery up to here. Then here it comes to a slight lateral side with an inclination. You see, this is the inclination. This is the inclination. And it is running in lateral side with a slight inclination. So upper part medially, then majority part behind, then comes with a slight inclination to the lateral part in lower part of the thigh in femoral. So this is the relation of femoral vein to the femoral artery. Femoral vein in upper upper part is medial, then it goes behind the femoral artery, and then it comes laterally with a slight lateral inclination. These are the 3 points you have to tell in the surface anatomy, and you have to mark them like that. First of all, you have to identify the femoral artery surface anatomy. Then in the upper part, femoral vein, you draw a line with chalk piece. Then you go behind the femoral artery, behind the line. Then you come with a slight lateral inclination in the lower part. That is the femoral vein. How you have to write in the examination. A dead body is kept there. The examiner will ask you, so mark the surface anatomy of femoral artery. Then you have to identify the mid-inguinal point. Then you have to adductor tubercle. then you connect both these two by a line, and that is femoral artery. If you ask femoral vein, then you go to the medial aspect of the femoral artery, then behind the femoral artery, then with slight lateral inclination in the lower part, so in the to the lateral side of the femoral artery, that is the femoral vein. This is the method how you have to write in the examination. So we will tell you in the practical. We have to answer in the examination. We will tell you in the practical also. We are coming to the college, then we will conduct the practical. That is also related to the theory and also the practical. Because a 2 month schedule is there. So within the 2 months, we have to complete all of your practicals. We have to make you well equipped with examination. This is a critical time because of Corona, but so majority of the students are not participating in the classes. Some are keeping in mute and going away. What we will do if you are not interested? Now, great saphenous vein in the thigh. It is represented by a line joining the adductor tubercle and the center of the saphenous opening. It is represented by a line joining the adductor tubercle and the center of the saphenous opening. I will show you. So, this is the adductor tubercle. This is the center of the saphenous opening. A line joining these two is the saphenous, great saphenous vein. So, saphenous opening a few centimeters below the inguinal ligament and lateral to the pubic tubercle. So, this is saphenous opening. If this is 2 to 3 centimeters below the inguinal ligament, but just lateral to the pubic tubercle. That is the saphenous opening, and also a line joining the adductor tubercle and the mid of the saphenous opening or fossa ovalis, saphenous opening, is the great saphenous vein. Now, gluteal region and back of the thigh, surface landmark, iliac crest. It extends from the anterior superior to the posterior superior iliac spine. It extends from the anterior superior, anteriorly, superior to posterior superior, anterior iliac spine, superior to posterior superior iliac spine. Posterior, anterior iliac, superior iliac spine to posterior superior iliac spine. So, if you observe the iliac crest, you see the blade of the iliac. So, the hip bone is made up of 2 bones, right hip bone, left hip bone. Each hip bone is made up of ilium, ischium, pubis. Ilium is a blade-like one. It has got anterior superior iliac spine at the anterior end and posterior superior iliac spine at the posterior end. Iliac crest is connecting these two in a curved manner, convexity upwards. You see, you can palpate the anterior iliac crest in your own body. So, anterior superior iliac spine. Below the anterior superior iliac spine, anterior inferior iliac spine is there. Below the posterior superior iliac spine, posterior inferior iliac spine is there. Iliac crest is nothing but connecting the anterior superior iliac spine anteriorly to the posterior superior iliac spine posteriorly, forming a arch-like convex. So that is the iliac crest. You have to mark in the body. So how? Posterior superior iliac spine, anterior superior iliac spine. This is the iliac crest. How it is. So how the hip bone is there. So how right hip bone is there, how he has marked it. How the femur is there. So this is lesser trochanter, this is greater trochanter, this is neck of the femur, this is head of the femur fitted into the vestibular cavity. Now this is known as gluteal fold. This is known as gluteal fold. This is known as gluteal fold. So this gluteal fold indicates the underlying gluteus maximus muscle. So this entire area is covered by big muscle, that is gluteus maximus muscle. So this gluteal fold limits the gluteus maximus. So this fold indicates this. So this is the gluteus maximus. So lower end of the gluteus maximus forms the gluteal fold. You can say gluteal fold. So a raising part on the back of the thigh is gluteus maximus. It is caused by the gluteus maximus. The gluteus is caused by the gluteus maximus. Now tubercle of the iliac crest lies about 5 centimeters behind and above the anterior superior iliac spine. Transtubercular plane joining the tubercles of both iliac crest passes through the upper border of the fifth lumbar spine. So you go to the behind and above the anterior superior iliac spine. So I told you anterior superior iliac spine, posterior superior iliac spine. I told you anterior inferior iliac spine just below the anterior superior iliac spine, and posterior inferior iliac spine just below the posterior superior iliac spine. Now you go just above the anterior superior iliac spine, you will find a tubercle in the iliac crest. Iliac crest is nothing but joining the anterior superior iliac spine and posterior superior iliac spine in a convex manner. Now, just above the anterior superior iliac spine, tubercle is there in the iliac crest. That is, the tubercle of iliac crest lies about 5 centimeters behind and above the anterior superior iliac spine. Transtubercular plane joins the tubercles in both iliac crest, passes through the upper border of the fifth lumbar vertebra. So, transtubercular plane corresponds to the upper border of the fifth lumbar vertebra. Supracrustal plane is represented by a line joining the highest point of both iliac crest and passes behind through the fourth lumbar plane. Now you imagine iliac bone is like this. Anterior superior iliac spine is there. Posterior superior iliac spine is there. Anterior inferior iliac spine is there. Posterior inferior iliac spine is there. And just above the anterior superior iliac spine, the iliac crest, tubercle is there. That is tubercle of iliac crest. So there is another tubercle on there, other hip bone. So these two, you connect these two. This is a plane of transtubercular plane. It goes through the upper border of the lumbar vertebra. Supracrustal plane is represented by a line joining the highest point of both iliac crest and passes behind through the fourth lumbar spine. Here I will show you. So this is the highest point of the iliac crest. So this side also highest point of iliac crest is there. If you connect these two, it goes through the fourth lumbar vertebra. This is the posterior superior iliac spine. This is the anterior superior iliac spine. This is the iliac crest. This is a prominence that is tubercle. It goes through the fifth lumbar vertebra, and this highest point of the iliac crest. This is the highest point of highest convexity of the iliac crest is the highest point of iliac crest that passes through the fourth lumbar vertebra. That goes through the fourth lumbar vertebral level. So we can identify it. That is supracrustal plane. That is goes through the fourth lumbar vertebra. Transtubercular plane, fifth lumbar, upper border of the fifth lumbar vertebra. Posterior superior iliac spine is represented by a skin dimple at the back. A horizontal line joining the posterior superior spines of both sides passes through the second sacral spine. Where spinal dura and arachnoid matters ends, and subarachnoid space filled with cerebrospinal fluid extends. Now, posterior superior iliac spine is represented by a skin dimple at the back. A horizontal line joining the posterior superior spines of both sides passes through the second sacral spine. Tubercle, crest of tubercle above the anterior superior iliac spine. It passes through the fifth, highest point of the iliac crest that passes through the fourth. Now we are going into the posterior superior iliac spine. I will show you where the posterior superior iliac spine is there. This is the posterior superior iliac spine. It goes through the second sacral vertebra. If you connect this posterior superior iliac spine with the posterior superior iliac, either the opposite side, it goes through a plane that is second sacral vertebra. This is posterior superior iliac spine. So this is the posterior superior iliac spine. This is the anterior superior iliac spine. So like that. So just below the posterior superior iliac spine, posterior superior iliac spine, a skin dimple. So that goes through the second sacral spine. There spinal dura and arachnoid matter and subarachnoid spinal dura and arachnoid matter ends. Only pyometer is there. They merges with the bone of the second sacral vertebra. Then the spinal cord contains only pyometer only. That means spinal dura, outer dura, and middle arachnoid ends there by fusing with the second sacral vertebra. Then only pyometer is there around the terminal part of the spinal cord, phylum terminale. Now, greater trochanter of femur. It lies about hand's breadth below the tubercle of the iliac crest. Hand breadth below the tubercle of the iliac crest. Chodandi. This is the iliac crest. This is the greater trochanter. You measure the distance between the iliac crest and the greater trochanter, that is a hand breadth. A hand breadth. So, greater trochanter lies hand breadth below the iliac crest. Lies below the hand breadth below the iliac crest. Gluteal fold. It is a horizontal skin fold which marks the upper limb to the back of the thigh. It does not correspond to the lower part of the gluteus maximus and is formed by the fibrous adhesions between the skin and nape fascia. It does not correspond to the lower part of the gluteus maximus and is formed by the fibrous adhesions between the skin and nape fascia, gluteal fold. Tuberosity of the ischium. This is my controversy. In my previous class, I told you lower part of the gluteus maximus forms the gluteal fold. Here he says it is nothing but a skin dimple, but usually gluteus maximus comes there up to that level only, muscle. But the fold itself is formed by the adhesion of the skin and the subcutaneous material, fibrous adhesion between the skin and nape fascia. Tuberosity of the ischium. It is palpable semi-flexed hip joint about 5 centimeters above the gluteal fold and the same distance from the medial plane. Now, this is the level of iliac crest. You see, intergluteal cleft are called as navel cleft. This is the buttock. This is the gluteal fold. This is the greater trochanter. This is ischial tuberosity. Where we will sit, ischial tuberosity touches between the ischial tuberosity and land area, and the area in which we are sitting. Skin, superficial fascia, deep fascia, and fatty material centering between the floor and also the ischial tuberosity. So this is gluteal fold. Then this is the thigh. This is the thigh. This is buttock. This is buttock. So this region is called hip region. So if you mark like this is hip region, this is buttock region, this is thigh region, this is buttock region, this is pelvic bone, sacrum, coccyx, this is a lateral flap, this is lateral flap, this is lateral flap, this is buttock region, this is hip region, this is thigh region. You see the diagram, it has become a clear cut. What are the divisions of the back of the abdomen, lower part of the abdomen and the upper part of the thigh. Buttock region. What is buttock region? You see repeatedly this diagram. With that, you cannot confuse where the sacrum is present, where the coccyx is present, where the pelvic bone is present, where the femur is present. So he has marked the underlying bones by a dark gray line. You see the diagram carefully, you will get a clear-cut idea what is hip region, what is buttock region, and what is thigh region. You see this diagram. It is a beautiful diagram. Okay. Now here sacrum, highest point of the iliac crest, gluteus maximus, intergluteal cleft or natal cleft, tip of greater trochanter, ischial tuberosity, gluteal sulcus. This is gluteal fold. The sulcus is formed. This is sulcus. This is fold. So iliac crest and four level. Intergluteal cleft, green color. You see this diagram. This is also a beautiful diagram. Now, Nelaton's line. It is represented by a line joining the anterior superior iliac spine and most prominent part of the ischial tuberosity. In normal, unusually normal conditions, Nelaton's line crosses the apex of the greater trochanter and the center of the acetabulum. Nelaton's line, represented by a line joining the anterior superior iliac spine and the most prominent of the part of the ischial tuberosity. This is ischial tuberosity. This is greater trochanter. A line joining these two is called as Nelaton's line. This is ischial tuberosity. This is greater trochanter. A line joining these two is called Nelaton's line. Posterior superior iliac spine, anterior superior iliac spine, anterior inferior iliac spine. Like that, you see, this is sacrum. This is two pelvic bones are joined. This is coccyx. This is coccyx. This is coccyx. You see this one. Now, Bryan's triangle. Draw a horizontal line from anterior superior iliac spine backwards with the subject and recumbent posture. Drop a perpendicular line from the above mentioned horizontal line to the top of the greater trochanter. Complete the triangle by joining the anterior superior iliac spine and top of the greater trochanter. When sides of Bryan's triangle are compared between the sound and the affected sides, upward or backward displacement of the greater trochanter can be assessed in dislocation of hip joint. How the surface anatomy is useful in underlying clinical anatomy. To draw the Bryan's triangle, both sides are same, both hips are normal. If one side is depressed, then there is a dislocation of the hip joint. So this is a Bryan's triangle. Draw a horizontal line from the anterior superior iliac spine backwards with the subject and recumbent position. Drop a perpendicular line from the above mentioned horizontal line to the top of the greater trochanter. Complete the triangle by joining the anterior superior iliac spine and top of the greater trochanter. When the sides of Bryan triangle are compared between the sound and affected side, the sound means normal and affected side means damaged or dislocated. Upward or backward displacement of the greater trochanter can be assessed in dislocation of the hip joint. Not downwards. Upward dislocation of the hip joint. Upward dislocation of the femur. So it indicates displacement of the hip joint. That means head of the femur comes out from the acetabular cavity because hip joint is formed by head of the femur and the acetabular cavity. Head of the femur occupying in the acetabular cavity, that is hip joint. You have to recollect your studies, then only you can follow the subject. Now, sciatic nerve. Draw a line joining the posterior superior iliac spine and ischial tuberosity. Take a point about 2.5 centimeter lateral to the midpoint of that line, which represents entry of sciatic nerve in the gluteal region. Now, you read this one. Take another point just medial to the midpoint of a line joining ischial tuberosity to the apex of the greater trochanter. Put a point at the upper angle of popliteal fossa. Join these points by a broad line which passes downwards and laterally and represents the sciatic nerve. A, B, C. You have to read it and practice it. You have to read these three. Draw a line joining the posterior superior iliac spine and ischial tuberosity. Posterior superior iliac spine and ischial tuberosity. Draw a line joining the posterior superior iliac spine and ischial tuberosity. Yeah. Drop a perpendicular line from the above mentioned horizontal line to the top of the greater trochanter. A perpendicular line. Second point. Perpendicular line drop cheyమన్నాడు ఇలా line drop చేసాం. Second point. That is second point. Complete the triangle by joining the anterior superior iliac spine and top of the greater trochanter. Complete the triangle by joining the anterior superior iliac spine and the top of the greater trochanter. ఇలా కంప్లీట్ చేయమన్నాడు. So if you draw this one, complete the triangle by joining the anterior superior iliac spine to the top of the greater trochanter. When the sides of the Bryant's triangle are compared between the sound and affected side, upward or backward displacement of the greater trochanter can be assessed and dislocated in the joint. It will be a difficult. Sight it down. Draw a line joining the posterior superior iliac spine and ischial tuberosity. Take a point about 2.5 cm lateral to the midpoint of that line, which represents entry of the sciatic nerve in the gluteal region. Take another point just medial to the midpoint of a line joining the ischial tuberosity to the apex of the greater trochanter. Another point just medial to the midpoint of line joining the ischial tuberosity. Midpoint of the ischial tuberosity. Another line. This is ischial tuberosity. This is greater trochanter. Then midpoint, usually the midpoint represents the entry of represents the sciatic nerve. Put a point at the upper angle of the popliteal fossa. This is popliteal fossa. Join these points by a broad line which passes downwards and laterally and represents the sciatic nerve. Now this is iliotibial tract. This is vastus lateralis. This is long head of biceps. This is short head of biceps. This is tendon. This is patellar ligament. This is vastus lateralis. This muscle is rectus femoris. So he had named the one. Gluteal fascia covering gluteus medius. 2. Gluteus maximus. 3. Tensor fasciae lata. 4. Site of greater trochanter. This is 5. Vastus lateralis. Long-headed, short-headed biceps femoris and tendon. This most prominent part is tendon of biceps femoris, which has got long-headed, short-head. Like that, you have to identify you have to see the underlying muscles, you have to mark them superficially. He has named the muscles and the numbering also given. Here, this on the surface, numbers are given 1, 2, 3, 4, 5, 6. Like that, he has given so many numbers. So, he has represented the underlying structures in the number. So, in this diagram and this diagram, you compare both of these with each other and study it it indicates how you have to identify the surface anatomy by underlying structures. You know the gross anatomy very well, you follow the dissection very well, you can easily identify the surface anatomy. That means you know the exact position where the organs are present in living body. That is essential for a doctor. What is present in the body, human body, you must know it. For example, if anybody comes and put a needle on your body, you have to mention what are the underlying structures present immediately below here. So you must tell it. That is the surface anatomy. You read this diagram, you see this diagram, you read this, you see this diagram, how numbers were given. So this is the surface anatomy. This is the purpose of surface anatomy. Once you know the gross anatomy very well, where they are present, you mark them in a living body. So where how underlying structures are there, you have to mark them on the surface of the body. That is surface anatomy. Now gluteal region, transition between trunk and lower extremity. Gluteal region, transition between trunk and lower. This is the lower extremity. This is the trunk. This is a transition. This is the trunk. This is the lower extremity. So gluteal region is a transition between the trunk and lower extremity. Anatomically trunk, functionally lower extremity. Includes rounded posterior buttocks and lateral shape. This is hip region. This is buttock region. This is thigh region. Now sacral hydrocele, sacral anesthesia. How you are giving? Just above the lateral cleft, you have to palpate it and you give sacral anesthesia. Second sacral foramina in extradural caudal anesthesia. Now this is, when you are giving injection here, sacral hiatus anesthesia, this is one. So if you just give above that one, that is S2 level, second sacral foramina in extradural caudal anesthesia. So leg and foot, surface landmass, tubercle of tibia. It is a subcutaneous projection of upper end of tibia where the ligamentum patella is attached in its upper part and the subcutaneous anterior part of the tibia extends below. Under the fibula, it is slight elevation on the posterolateral aspect of the upper part of the leg and lies vertically below the posterior part of the lateral condyle of femur. So you have to mark the underlying structures superficially. Now these are all the nerves, how they have given points and marked them. And you name the point, what is that point, and you name this point and give a connection between these two and the front of the leg. It is anterior tibial artery. It is anterior tibial artery. You identify the neck of the fibula, then you will find a deep peroneal nerve, how it is coming. So then you identify another, that is superficial peroneal nerve or otherwise muscular cutaneous nerve. Now this is the inferior extremity of the lower leg. Now neck of the fibula, it is a constriction below the head of the fibula where the common peroneal nerve can be rolled against it. Medial malleolus is a visible prominence at the lower end of the subcutaneous medial surface of the shaft of the tibia. Lateral malleolus is a conspicuous projection on the lateral side of the ankle and lies at a lower level and on a more posterior plane than the medial plane. So if you compare the medial malleolus and lateral malleolus is more prominent and it is at a lower level and most posterior plane when compared with the medial malleolus. And now the time is 1:30. Already you are exhausted and you read it. We are communicating the PowerPoint. And thank you very much for your time, patience. Thank you very much once again.